Well, I think you kind of have to go back to before the original phase 1 study was performed. The de facto standard of care, at least in the United States, was the use of hypomethylating agent monotherapy in patients who are older or unfit for induction chemotherapy, and those treatments in the monotherapy setting were associated with pretty low response rates and modest benefit in that population. And so there was really a big need for improvement in the outcomes for that population. And then, the disease AML it's been really fascinating to see how it's been molecularly dissected and the biology elucidated in the laboratory with all the kind of great investigators out there. And the dependency of the disease and even its leukemia stem cell population on the BCL2 protein has become apparent. And then venetoclax was designed to target this. And so, emerging as a potential useful treatment in AML. And so after it was shown to have some single agent activity in an initial phase 1 study, the clinical trial was launched to look at it in combination. And that trial has shown success, and it's been reported in Lancet Oncology and Blood as a very promising and exciting regimen for these patients with high response rates and very promising survival data. So that's really the initial rationale that led to those initial studies. Yeah, I think that's an important question. Following it's been approved by the FDA here in the United States with the label indicating that it can be given to anyone who's 75 or older. And then for patients who are less than 75, it can be considered in certain patients with certain comorbidities, for example, lung or heart or kidney or liver or bad performance status or high performance status. And so those are the patients that are eligible for the treatment. And so I think that's obviously some important factors when one is deciding whether to start the regimen. And I think there's other factors that are involved, at least on an individual patient basis, including, these are mostly older patients, so you got to think about their support. In other words, family members or other folks that can help them out with attending appointments or getting to infusion centers. One has to think about resources available in terms of being able to give people transfusions and adequate supportive care. And then again, it's assessing the individual patient in terms of their own comorbidities, but also their goals of their treatment and how, what are they after? Are they after quality of life as number one goal, quantity of life as number one goal, or some combination of the two? And I think it's very individualized. It's always a very interesting experience to meet a new patient with this disease and kind of go through all these things and really get a sense of what they're thinking. We've noticed clinically, at least in the phase 1 study, both the LODAC and the HMA study, combination studies with venetoclax, I should say, that the responses are very fast. And this is a departure from our historical experience with hypomethylating agents and LODAC monotherapy. So most patients are achieving complete remissions within 1-2 cycles. And so, there was an initial thought that perhaps, if a patient didn't achieve an early response, then maybe this wasn't going to be the regimen for them. And so we realized that this hadn't really been looked at in a more formal setting. And so we aimed to ask that question with this study, and we were able to combine data sets from the two pretty large, for phase 1 studies with the HMA plus venetoclax and the low-dose cytarabine plus venetoclax trials to get a sense of when patients were achieving remission, which ones were achieving remission perhaps later, were there any biomarkers that might help us understand who was going to achieve a remission or who was not, and the impact of that maybe on our clinical practice. The study was interesting. we know that there was a large percentage of patients that achieve a remission fast within 2 cycles. But what actually I found a little surprising, perhaps, was that a third of patients achieved a response after cycle 2. And in the HMA combination arm, for example, 90+% of patients achieved a remission by cycle 4. So that was interesting to me. We looked at other aspects of, survival kind of followed how fast one achieved a remission. Certainly it was way better than people who had no response, and none of that's very surprising. And of course, these are, trends not formally assessed statistically, so to speak. And we looked at the subsets of patients, and I think, what we kind of knew all along, which is the IDH mutated patients are doing well, the NPM1 mutated patients are doing well, and it bears out here that they are achieving early remissions. There was another analysis we did that I thought was really interesting, looking at other factors that could predict maybe someone who had gone through 2 cycles and hadn't achieved a remission, if they had a good chance of achieving a late remission. And using that type of analysis, we found that patients with secondary leukemia and who hadn't had a response or blast clearance by 2 cycles were less likely to achieve a remission later. So I think the overall, again, I found the number of patients achieving a later remission higher than I expected. And I think this is really an interesting result because it basically tells us that we need to think about each patient on an individual basis as to whether or not to continue the regimen for a longer period of time or whether or not to move forward with a different treatment option. Yeah, this is a question that actually leads to a fair amount of debate, I think, or difference of opinion depending on who you talk to. And if you look at all the academicians out there, different big centers, I think you'll find that there's some subtleties to people's management. For me personally, I utilize venetoclax dose reductions, not in terms of the actual dose, but decrease in the duration of the venetoclax. Based on response and on cytopenias. I've also used breaks between cycles to allow for count recovery, and I've used growth factors in some patients to facilitate count recovery in patients that are in a remission, a deep remission, I should point out. And so I think there's a lot of different things that we're using to mitigate these things. I think I also use a fair amount of antimicrobial prophylaxis to help in patients who have cytopenias. That doesn't help prevent the cytopenias, of course, but preventing the complications related to the cytopenias. And in my hands, in my experience with these measures, I've been able to, I think, for the most part, avoid any complications or frequent complications. And I think this is an area that actually is important for us to learn more. And I think this is another area, as I've mentioned to my colleagues and to other people, I think real world evidence plays a role in helping us to understand how to look at these questions and see what people around the country are doing to deal with the cytopenias and whether or not those have any impacts on the overall survival or duration of remission. I think is very important questions to ask scientifically, at least.